Good morning, ladies and gentlemen. Thank you for joining us today for Grand Rounds. We've got people logging on one at a time here, so I'd like to do a brief introduction while we're waiting to have our full audience gathered. My name is Jed Thompson. I'm the host of Grand Rounds, and today's presentation is sponsored by the Department of Psychiatry and Behavioral Sciences at the University of Washington, as well as the Behavioral Health Support Specialist Fund. Before we begin, a few logistical items I'd like to go over. If you joined us before, these will be familiar with you, but if you're new, welcome. And I'd just like you to know that we will have an evaluation form at the end of the presentation today. So if you'd like to provide any feedback, just wait until the webinar ends and then you'll see a link. We'd love to get your feedback. So go ahead and use that if you have a few extra minutes following the presentation. We have another presentation scheduled for next Friday, May 16th. That'll be our next Grand Rounds. And we'll be joined by Dr. Stefan Heckers, who is the chair of the Department of Psychiatry at Vanderbilt University. He'll be joining us next Friday, and he'll be talking to us about catatonia. So please plan to join us for that one. One new thing today, we actually do have the chat feature activated. So if you'd like to have any conversations amongst yourselves during the presentation, go ahead and type in the chat. That will be open for everyone to see and to read. So we'll give that a try. And then as always, we'll have a Q&A session at the end. We'll try to leave 5 or 10 minutes for your questions. With any questions that you'd like to ask the presenters specifically, please use the Q&A feature. And then at the end, I'll have those queued up and we'll do those live, answer those questions live for everyone. So it looks like we have most of the people on now. So let's go ahead and begin. I'm going to toss it over to Dr. Jürgen Unitzer, who's the chair of our department, and Jürgen is going to introduce today's speakers. So once again, welcome everyone. Thank you for joining. And Jürgen, I hand it over to you now.
Okay, thank you, Jed. And the first thing I'm going to do is answer one of the chats. Yes, we are recording all of these Grand Round sessions. They will be up on our department website either later today or sometime next week, right, Jed?
That's right. Yep, that'll be up there soon.
Okay, so welcome to today's Grand Rounds. Today we're going to hear an update on a really interesting, innovative effort to expand the behavioral health workforce in our state from two of our department colleagues, Drs. Anna Ratzlaff and Bill O'Connell. Before I turn it over to Anna and Bill, let me say just a few words about our speakers today. I'll start with Anna. Anna Ratzlaff is known to most of you. Anna holds an endowed professorship in our department, and she serves as our vice chair for faculty development. She trained at Stanford and UC Irvine, where she got both an MD and a PhD. Before coming to UW as a resident. In our department, she co-directs the AIMS Center along with Diane Powers, and Anna and Diane just recently did a really nice Grand Rounds, an update on 10 years of what's happened in that program. She partners on research, training, and implementation support projects in collaborative care with colleagues really all around the country. She has also a tremendous amount of experience with training and workforce development, training all manner of healthcare and mental health professionals in behavioral health in general, but for example, suicide prevention specifically. She served as a former director of our psychiatry residency program, and she has directed several really innovative mental health workforce development programs over the past decade. And you're going to hear about one of those programs, one of those efforts today. Bill O'Connell is an associate professor in our department. He directs this project you're going to hear about today, the Behavioral Health Support Specialist Workforce Development Project. Bill is a licensed mental health counselor and a nationally certified counselor with expertise in counselor training and supervision. He got his doctorate from the University of Cincinnati with a specialization in behavioral medicine, and he's worked both as a clinician and as a leader in community behavioral health and integrated primary care. He has had previous appointments as a tenured faculty member and an administrator at Seattle U, at Xavier University in Ohio. And his scholarship really includes best practices in counselor training and education, work on ethical dilemmas in practice, and workforce development. The last thing I'm going to say before I turn it over to Anna and Bill is that they wrote an article together last year, was in Psychiatric Services in 2024 about this behavioral health support specialist career path program. And that article got a lot of attention and was featured as one of the most accessed articles in that journal in 2024. So with that, I will turn it over to Bill and Anna, and I think we're in for a really great presentation today. I look forward to it. Thank you both.
Thank you so much, Jürgen. We appreciate it very much. And Anna and I are very pleased to be here. As we begin, we want to just mention that the Behavioral Health Support Specialist Workforce Development Project has been generously funded through Bomber Group. And we have no other financial conflicts of interest related to this presentation. And so our Anna is going to start us off with giving an overview of the problems we were attempting to address as part of this project. But our vision for the behavioral health support specialist is some of our solution development ideas and an overview of our progress. I do want to point out that there is a website for BHSS that's hosted by UW Psychiatry. I will post that a moment in chat. It does have some of the resources that we'll be referencing in our presentation today. So with that, I will turn it over to Anna.
All right. Well, thank you for that nice introduction. And I'm really excited to be here today and present with Bill. We've been working really closely on the work that we'll present today over the last several years with a number of people in our department who will, talk about throughout the different phases. But I want to kind of start back at the beginning for how this project really started. So we started a number of years ago at really the first mental health summit, presenting this idea, and it was a collaboration between myself and Pat Arian. And we really wanted to start to think about this problem of the behavioral health workforce shortage. And I think that this really came up for me in my other work supporting collaborative care, and that often I was seeing practices wanting to improve their access to mental health services in primary care settings, but really struggling to identify workforce to hire and really be available to help provide that full range of treatment. So this is often out in settings. Preferences for patients are for starting a lot of times with psychotherapies or brief interventions, and that access is often really limited, and especially when you get into our under-resourced communities, which really in Washington State is almost everywhere except for Spokane and King County. So if you think about it, we really need improved access to those services and really leading to increased access to care for all. Let's go ahead and go to the next slide. So one of the things we started to do is really think about what is the current workforce made up of and how might we bring new people into the workforce. So this slide really represents kind of the proportion of people that have potential training to be involved in the mental health workforce. The two smaller pictures really represent that the majority of the workforce right now that is available to hire really requires either masters, that sort of middle section. There's quite a number of people who graduate every year with a master's degree in either social work or counseling, psychology, or doctoral level work to be able to provide mental health services. However, there are a ton of people that graduate every year with either a psychology degree or a bachelor's in social work and aren't able to really be part of the workforce is really considered, I think people talk about psychology as being one of the most underutilized undergraduate degrees that's out there. And at the year that we started this project, we actually had, there were 125,000 people across the country who graduated with a psychology degree, but that workforce really can't enter. They don't have skills. They don't have the ability to enter the workforce and actually be part of the workforce right away. So we started looking globally at what could be some potential solutions to really maybe take this available group of people who were already showing interest in being part of the mental health workforce, either through getting a degree in psychology or a degree in social work. And how can we maybe bring them into the workforce more directly without having to wait 2 to 5 to more years for them to actually get enough training to be part of the workforce? And what we found is that internationally, we've seen a lot of work showing that bachelor level providers, when trained with specific skills and given specific skill development, could actually be a really important part of a solution in providing access to psychological treatment. A lot of this work came out of the UK and a program called IAPT that's now called Talking Therapies that has really shown that by training up a group of, they call them mental health well-being practitioners, you could actually lower the barriers to access to psychological treatments. So based off of that, we really said, how could we do that in Washington State? So what we'll talk about for the rest of the presentation really is our work to develop both the sort of legal mechanism and all the legislation and pieces that we needed to do to actually create a new certified provider in Washington State, as well as all of the work that we've done to really catalyze creating a quality training program and skill development program for this workforce. Let's go ahead. And that's going to be called the behavioral health support specialist. I didn't say that out loud, but that's what we're talking about. So what are we really talking about in the vision for workforce? So as I mentioned, most of the counties right now in Washington State are considered under access for mental health providers. So everything except for King County and again Spokane really are considered mental health workforce shortage areas. So we're thinking, how could we create a workforce, catalyze a workforce that could be in all of the counties across Washington State, would have the skills to deliver psychotherapies and brief interventions, but also be ready to work in a variety of workplaces. So you can see in these pictures here that one of the real advantages that we've seen in some of that international work is that these are folks that could work in mental health care settings, but also could be working in primary care, in schools, and in community settings. So our vision really was, if we were wildly successful with this program, that we would have a workforce trained, bring new people in that hadn't previously been part of our workforce, and really have them develop both the skills and the knowledge to be able to work in a variety of settings across Washington State. We can go ahead and go to the next slide. So how did we do that? We received the funding from the Balmer organization, and what we really sought out to do is not train all of those people at the University of Washington, in part because, there's only so many people that are actually here going to school, but also really thinking about, if we were wildly successful, every 4-year degree granting institution would be able to add in the core components that you need to get a certification as a behavioral health support specialist into their 4-year undergraduate degree. So these include both our traditional 4-year universities as well as many of our community college system that actually now offer something called a Bachelor of Applied Science. And so they also offer 4-year degrees. And what we really the vision that we had is that we would be a catalyst. We'd create the infrastructure, we'd create resources, and Bill will talk a lot about how we did that, to allow any of the programs to add this curriculum in. We think that this would be about a year roughly worth of content that each of these institutions would also offer a practicum experience in a clinical setting where people would be able to develop their clinical skills. And this is a map of the current partners that we have right now that either are implementing this program or plan to implement it. In this, we'll talk a little bit in the next slide about the timeline, but this will actually become a certificate that people can apply for starting in July of this year. And we anticipate that there'll be about 40 to 50 people that actually will be eligible to apply for that certificate this year, graduating from some of these great educational partners. Anything you want to add to that one, Bill?
Yeah, I would just say that we do have more partners who are planning to do that you did not see on that map. I just met with a major university this morning in person, and they're planning to join. But I won't give the name just yet. But it's exciting to hear that more colleges and universities are really interested in this.
Yeah, and I'll just say I'm really excited that you could see those really were represented across Washington State, because there is a lot of evidence that when you train people in the communities that they're already living in, they are more likely to stay and serve those communities. And as we mentioned, that's a really important part of the solution, is that we would be training people, hopefully in some of those communities where there is a workforce shortage, and that hopefully they'll stay and practice and provide clinical care in those underrepresented areas across our state. So this was a big, bold vision, but actually needed a lot of really important things to happen. And sometimes things happen not exactly as you intend them to. So we had thought we'd work on the curriculum, and we would, at some point work with the legislation process to actually develop the scope of practice and the certification and all of that. But very early in the project, we actually had a champion, one of our senators in Washington State, Senator Trudeau, who got very excited about this program and actually helped champion a bill, SSB 5189, which actually established the BHSS as a new provider type. And so that was very exciting, but it also meant that we've been working fast and to keep up with the timeline to actually do all the things that we needed to do to actually make this happen. So part of that bill was actually required that they worked closely, the Department of Health worked closely with us to actually define how that criteria would be established for that certificate. We also have worked with the Healthcare Authority, and I'll talk a little bit more about payment in a few minutes. We had to find educational partners quickly and get a lot of community input. And I think it's also been really helpful to have just broad community engagement across a number of areas, so that we really are, on track to be able to have this new workforce be able to work in a variety of settings in Washington State, which is really new for Washington State. There have been bachelor level people that have provided services, but they often have had to be in only behavioral health certified agencies. And so it really limited how we could access this workforce. Anything else to add? And this is the picture actually of the bill being signed. And was a very exciting day for all of us who've been working on this project.
So Anna and I would like to talk a little bit about how we see the work we've been doing and how the funding has been utilized for building this new profession. And we see it in two phases. So the first phase, we're coming to a conclusion with this year, and then moving into this next phase. So I'll just summarize the first one. Anna will summarize the second one. So what we started with was really a backward design for how we would develop a model curriculum for this program. So one of our first efforts was putting together a competency framework, meaning what are the skills that we really wanted a behavioral health support specialist at the bachelor level to have as a result of receiving specialized training and education. And so in 2022, we conducted a series of focus groups that involved industry partners from across the state representing our behavioral health agencies, our integrated care providers, other human services, our substance use disorder treatment partners. Also, there were government agencies and professional associations involved and so forth that gave feedback around what's the right mix of competencies that someone need to have. And so from there, we developed a curriculum map that's quite extensive. It has almost 500 knowledge, skills, and attitudes tied to it. And then we put together an implementation guide with the focus being our education partners on how they could begin to align their programs with these competencies. In addition to that, and I'll talk a little bit more about this, one of our faculty, Patrick Rowie, was working on the intelligent tutoring system, which is a partnership with our computer science and engineering school to really help deliver the curriculum in a more efficient way. So we'll talk more about that. We've advocated for credentialing, and we've been really involved with that process. We're in the process of completing an educator's guide, which will have a full curriculum available to any Washington State College or university to help with the process of integration into their existing four-year degree programs. We'll continue to deliver training and education or in socializing the community to this role. We also want to develop and have been in the process of developing a supervisor training, likely to be asynchronous, that supervisors can use to become acquainted with the BHSS and best practices in supervision. Another project we have going on is mapping the competencies that are currently for adult care to what we think would be the adolescent needs in adolescent settings. So we have a group of subject matter experts that we're currently consulting with to really think through what that might be. And none of this would be possible unless we were working with a very talented group of people to make this happen. So we do want to acknowledge many of our partners that have been helping us with this. We've been working with our education team, Alan Gojix, Melissa Farnham, and Sarah Achella, who are instructional designers, have been really integral in this work. We've also been working with a number of talented faculty who I'll mention a little bit later. But I want to also call attention to the work of Diane Powers and Sarah Barker, who have been really great consultants to us as we've been working on this as well. So I'll pass it to Anna.
Yes, so we have about another year of funding that we're working with, and the work that Bill just described, I think, is really where we'll be focused over that next year. And through our work with our community partners and educational partners, we've identified a number of areas that we really think of as sort of the phase 2 of being able to get this workforce out and actually being utilized in community settings. So one of the things I didn't focus on, but I think is really important to understand about the BHSS, is that they are able to deliver treatments, brief treatments like behavioral activation, modular anxiety treatment, harm reduction, and Bill will talk a little bit more about that. And they have the requirement of ongoing supervision. One of the big differences between this bachelor's level workforce and a master's level workforce is that they will not have within their scope of practice to diagnose. So they will always have to be working under the supervision of someone that can make a diagnosis and will be providing ongoing support as they deliver treatment. So we've identified a number of additional needs that we really see as kind of phase 2 of supporting this workforce. The first part of that is really thinking about how do we prepare supervisors to support a bachelor's level workforce. I think this is often a new skill, and I think given my experiences in other training programs and developing other supervisors, it's often really important to have specific training in what that person that you're supervising can actually do, what they can't do. How do you manage some of the complexities that can come up in clinical care? We've really found that the educational partners are often really well prepared to provide the curriculum of didactic content, but teaching skills to bachelor's level folks is often a new endeavor for most of the educational partners. So really thinking about how do we support them being able to develop that capacity, also making partnerships with community organizations that can provide a practicum experience. So I think that's going to be an ongoing area where we're really going to be working. Again, focusing on expanding beyond adults to adolescents and young adults. And then really be thinking about, as there now is going to be an actual workforce to hire, how do people really integrate this new workforce into their workplace settings? What does that look like? What roles can they take on? How do they communicate about what their skills and competencies are within the workplace? We think will be the next sort of area of focus that we'll want to catalyze growth and partnership. We have a lot of workplaces that are interested in this, but they are still trying to figure out, how does this person actually work within our settings and be successful in offering new access to mental health services. And then, very importantly, I mean, we're an academic institution, but also this is a brand new workforce. We will want to focus on evaluating the impact of this workforce. And there's a number of people within the department who are partnering with thinking about, how do we do that well? So I'll go ahead and pass it back to you, Bill.
Thank you. So we would like to take some time to talk a little bit about the curriculum itself, and at least provide a flavor for what it is and how it's unique and really important part of this project. We've been working with a number of faculty on this. Some really close partners have been Patrick Rowie and Brenna Wren and Pat Ariane. I think we're also working with other faculty throughout our department: Susan Collins, Akancha Vaswani Bai, and also external faculty as well, to help put together a good model curriculum. So what we arrived at were 8 competency domains. And each of these domains has a total of 34 competencies between all 8 that we're addressing in the curriculum. And I think we looked to a number of sources to arrive at these domains. And that included both models, national models for delivering mental health care, but also integrated care models, and best practices from international and national task sharing literature as well. So just to give you a little sense, I think, of what makes the BHSS unique is that we will be doing training around screening and assessment. So Shannon Albert, who's a psychologist and former director of the integrated care program at Swedish Hospital, has really helped put together an excellent curriculum around training the BHSS to be involved in screening, to score common screening instruments, be able to talk about those screenings with a patient or a client, and then be able to collaborate with the team on case formulation and their supervisor around decisions regarding treatment. So I think this work is just really essential, and they'll be contributing to the assessment process. As Anna mentioned earlier, the BHSS does not diagnose, but they can help contribute information to the diagnostician. Also, I think that this is an appropriate level of work, especially within integrated care settings. I think the heart of what we're really creating within the curriculum are these psychosocial interventions themselves. So Susan Collins and Annie McGuire have helped put together the curriculum for motivational interviewing and psychoeducation. And I think this is a great place to start. Almost all of our employment partners, who are also our practicum and internship partners, they've really suggested that this is an important element to bring into the workplace. So Susan's just done an outstanding job, I think, of providing us a terrific curriculum around MI. And then we're also looking at how can we help the BHSS be prepared to manage acute crises that occur across settings, and then also work with substance use concerns. Because in Washington State, there is a certified substance use disorder counselor, we didn't want to interfere with the scope of practice that already exists for that particular provider type. So in consultation with many of our UW partners and external partners in the substance use treatment field, we arrived at harm reduction as an appropriate intervention for the BHSS to understand and to be able to exercise. And again, Susan's done a tremendous job of really helping us think about harm reduction treatment and how that would apply to a BHSS. And we'll be continuing to develop the distress tolerance curriculum, which will include problem solving and relaxation training. And from my experience working in integrated care, if you have those skills down, you can address at least half of the issues that patients bring into the clinic setting. And then again, the big pieces would be Patrick Rowie has developed our behavioral activation curriculum, specifically aimed at helping to alleviate symptoms of depression. And then Brenna Rem has helped put together the CBT for anxiety, in particular, focusing on strategies that will make sense within a brief intervention format. And so we're excited about this work. I also think our education partners are really thrilled with how we were thinking through this. And we're already hearing that practicum partners think this is sort of the right recipe, if you will, for a person starting out in the field and being prepared to enter into the workplace and start working with patients and clients. A real concern among the professional associations when we were conducting the focus groups was around legal and ethical concerns. So we have an entire chapter that's already up online to view around legal, ethical, and professional issues, especially at the bachelor level. And I think it really starts with values exploration within many of our undergraduate programs. That could even occur in a philosophical course. But there's going to be a need for more advanced training and thinking about how to develop the reflective practice. And so I think a key component is helping our bachelor level folks to have a good understanding of ethical decision-making and have an ethical decision-making model to work from that fits within the identity of that particular program, whether it be psychology, social work, or behavioral health care, and having a focus on risk reduction so that we're helping to launch a workforce that's going to understand what their responsibilities are, not only to their patients and clients, but to their employer and to the community. One of the really important components of, let's see, my PowerPoint reloading. One of the important components of these this work is really the ITS program, which is been a really critical component of what we've been developing to help our partners really think about how they can scale training in settings where they traditionally have not taught clinical skills. So this partnership with computer science and engineering has helped to lead to the ITS program. Again, this is available on our website for view. So if you're interested in exploring it, you can. I'll give an example of it in just a moment, but it covers select topics that we think would be really helpful to provide more practice for our education partners to deliver to their students, and they can easily integrate ITS into their Canvas learning management systems. And we have a number of folks who have been using this already. So this has been tested out with our own social work program, as well as with many of our ed partners at EWU and other schools. It's currently being used by 3 of our active BHSS programs. And actually our I think one of our nursing programs is using this as well. We're really excited about the opportunity that students will have to really build skills quickly and be prepared for work. So what ITS does is it delivers a number of scenarios. Initially, it may be a scenario that is presented to the student with some possible responses, and they're asked to pick the most accurate response around the topic that they're addressing. If they don't pick the correct response, they'll receive a prompt to try again, and they can go back and do that. If they're still struggling, ITS will stay at a level that allows them to learn that particular concept related to the skill until they've achieved enough success with it to move on to a more difficult level. So what we find, and this holds true, is that students who come in with some experience, like case managers into one of these programs, they typically move through this a little faster. And then students who have had no exposure to some of these skills will take a little longer. And our faculty are confirming that that tends to be the case. So again, this is one, I think, of the products from the clinical training program that we're providing to our partners. We want to now talk a little bit about practicum, and one of the things that our team believed would be really helpful in, I think, gaining the confidence of employers to hire someone out of a bachelor's program was to have a clinical practicum. We do use the words practicum and internship interchangeably because some of our partners were already using that term, and we didn't see a reason for them to have to change that. But this is a experience that will come later on in the program. So what we envision for most of our bachelor's programs is that whether it's in a community college system or it's in a traditional university, the majority of BHSS training is going to be in their 3rd and 4th year. So this would be the 2 years of the BAS program. And the practicum would likely fit into the 4th year. And in some programs that will happen in 2 quarters, and in other programs 3 quarters, or in some programs there's only a couple on the semester system, it may be 1 semester. And it's an opportunity to really work alongside practitioners and understand how to practice patient engagement and co-deliver services with an experienced professional so that they can better adapt to their role. So the practicum will be a minimum of 240 hours with 60 hours of direct service that may be co-delivered. They'll need an approved supervisor, and that's someone who can diagnose and treat mental and behavioral health conditions. And something that UW advocated for was that we have a broader view of who a supervisor could be, with the idea that we really wanted to see this role supporting some of the counties in Washington where there really are no mental health providers. And so we've already seen success with this. So there's students on the east side who are currently right now doing practicums in very rural areas of the state. And their supervisor is a physician who's a primary care provider. And in addition to working with the physician, they have a supervisor who's usually an LMHC or LCSW, helping to support them through distance supervision to be able to work with patients in an integrated care setting. I think there's been a lot of receptivity to this and excitement about this in our rural counties. And so we're really, and I also really appreciate the partnership with Department of Health to figure out the right way to make sure that students are appropriately supported. And thinking that these practicums can really occur anywhere mental and behavioral health services are offered with appropriate supervision. So another example would be in supportive housing. And one of the tasks that I had at my previous job with Seattle University was expanding internship sites. And I worked with a supportive housing service that's not a licensed behavioral health agency, but did have access to a licensed mental health counselor to supervise the students. And we created a learning experience there for people who typically didn't have access to mental health services. And it was very successful. And so I think these are opportunities that can happen with the BHSS role as well. Again, wherever appropriate supervision is available. Now, Anna's going to talk a bit more about policy and payment.
Yeah. So one of the things that we have been thinking about since the very beginning is that it's really important that future employers can actually bill for the services that people are providing, that the new BHSS providers will be providing. And so we've been very involved in thinking about that from the beginning. So that has included really thinking about, as we did our work with DOH, making sure that this person would have an independent credential, even though they'll be under supervision, so they could bill for their services. We've worked very closely with HCA. They've been an incredible partner on really trying to identify a full range of billing strategies for both behavioral health agency settings, as well as primary care and non-agency settings. One of the things that came up is that when you create a new workforce type, typically one of the ways that people identify what billing strategies are available is under what is the taxonomy for that provider type. So if you're a physician, there's a certain list of codes that you can bill for. If you're a master's level psychologist or licensed social worker, there's a list of codes that are federally defined that you can bill for. Because this is a new provider type, there was no taxonomy for this provider type. So we have also been working to apply for a taxonomy to be created for this. We supported, HCA did that application, but we've been supporting that work because that will become very important down the road. And again, thinking about a broad range of settings that we can actually that there can be reimbursement for. And then the last thing is really then also developing and engaging with other payers, especially our commercial plans, to make sure they're aware of this provider type and are thinking about what billing codes they would allow under their plans to be able to really be able to support this workforce, because they are really thinking about how can they improve access to mental health services, behavioral health services for the people that are carrying their insurance plan. We can go to the next slide. And I mentioned evaluation a little bit in the beginning. We are starting this work now because we have a really unique opportunity to follow a new workforce coming out into the communities and really be able to think about what do we need to understand right now and how this is working to continue to catalyze the spread of this workforce. But also we have a pretty unique opportunity to really see how that evolves, how people do start to think about how to bring this workforce in, where are the settings that naturally is happening, where are those settings that we need to maybe spend a little more time supporting that implementation. So we are starting right now with developing surveys. We're hoping that we're going to try to engage every student that graduates in an invitation to participate in longitudinal surveys so we can learn more about how people who graduate with the endorsement to be able to apply for this credential actually how do they get into the workforce? Do they actually get certified? What works, what doesn't as they do that? That will also help us, I think, learn more about how and get feedback on the curriculum. Are there changes that things that we didn't anticipate that really should be a part of their core training? We also hope to track employers and practicum sites to learn more about are there barriers and what are the facilitators in really utilizing this new workforce? And then ultimately, we would really like to understand the quality of care that this workforce is able to deliver. There are a number of people. We will see one slide at the end. One of those is Alex Rose, who's one of our T32 fellows, who's been working on this, as well as Brittany Blanchard and Aaron Lepore and Greta Wren. So a bunch of people working with us on that.
We are moving towards the final part of our presentation. So we'll just explore challenges, some of the progress we see. We'll let you know about Alex's study, and then we'll take questions. So I think some of the challenges that we have encountered are really, as part of the project, is balancing work involved in curriculum development with also policy development at the same time, and understanding all the different the complex world that we're helping prepare the BHSS for. And so, but I think there's also been maybe an advantage to those happening at the same time, because it's actually helped inform some of what we've been doing. So but I think the integration of this curriculum is going to take time. So as Anna mentioned earlier, we're UW are really a catalyst for this work, and we want to help support all of our education partners in integrating the curriculum over time. And I think the Department of Health has been a great partner in this also, because they understand that process, and they're making some allowances for that as programs seek approval, giving them some time to do that. So we're really grateful for that. And then acknowledging, though, that there's a shortage of practicum supervisors. Something I didn't mention was that we also advocated that associates be included in the supervision list, which expands the possibility of the supervisors who could be working with the BHSS and practicum. And associates are receiving supervision of supervision. And so I've also been told, though, by some of our training programs that they're excited about this because, for example, at some of our psychology programs, they train people in supervision, but the students don't have anyone to supervise. So now they do. And I think that that's an opportunity. But it doesn't, in some places, there may be some competition for supervisors between master's seeking students and bachelor seeking students. I don't see that as common everywhere, but it could happen in certain geographical areas. And then really supporting employers, they have to really think about a job description. And we have created job descriptions before, but we may have to revise those and modify those to really help employers think about what a BHSS can do and how they're going to fit into the workflows at in different settings. So in terms of progress, the Sentinel Network actually presented recently. I was attending a meeting where they presented on data they've collected on what the employers need from the new workforce coming in. And maybe I think the word I would use is aligns, not matches wasn't really the right word, but the work that we've been doing aligns with what the employers are asking for. And so I was really heartened to see that because of all the work that's been going into this. It's just helpful to see that we're on the right track. Again, we have currently 11 colleges and universities, and I mentioned there are more who will be joining in this effort. And I really appreciate the vision that Anna has had to really scale this role by sharing this curriculum with any college or university interested in offering it. And we are training BHSSs right now through some of our programs. And as Anna mentioned, there'll be some graduates this year. If you're interested in, if you are part of an employer in Washington State and you're interested in participating in a study, we do invite you to use this QR code. We can also make it available to you in other ways. Alex Rose is really interested in talking with anyone who's willing about their perception of both barriers and facilitators for this kind of new role. And to contact us, you can go to bhsswa.uw.edu. Please sign up for our quarterly newsletter. You can also visit the website that we put in chat. And the Department of Health also has BHSS information in terms of application for the credential and education program approval and what the standards are for practice for a BHSS. And I think I will stop the share and we'll just move into any questions anyone might have.
Okay. Thank you both. So we do have some questions lined up here. And folks at home, if you have any questions, go ahead and put those in the Q&A. I see one over here in the chat, so maybe we'll start with that. Someone has asked if there's going to be any BHSS jobs available when the licensing exam is available to take this summer. And then the second part is, will that pay a living wage?
Yeah, so what we expect is that students who graduate from either provisionally approved or approved programs will be eligible for the BHSS. So if they are not part of one of those programs, they won't be eligible. Okay. So for those students, they will have completed practicums. And I think the employer is already looking at the possibility of hiring them in. I am also in dialogue with some HR managers about thinking about job descriptions. I think the best way to think about it would probably be it's going to fit somewhere in the pay scale between a case manager and a licensed associate. So it sits in between those two. And in terms of salary range, it's going to really depend on the geographic area. So the east side is going to look different from the central part of the state, from the south part of the state, from, it's just so different depending on what county you're in, right? So I think a good resource would be to look at some of the search engines that have the postings for those job descriptions for both case manager and associate, but find them in the same geographic area. And then I think you'll land on probably where that salary range might be. So that's how I would respond to that. If Anna, you have something else.
Yeah, I mean, I think I would answer that question the same way that you do. I think we also, it's one of the things we want to track on is what does that wage look like? Again, we think that it will fall somewhere in that range, but more than a case manager, but less than a master's trained person. Hopefully maybe we'll get to do an update at some point and actually talk about what this looks like out in the workplace now that there'll be an actual workforce to study.
Yeah, so kind of along those lines, someone's asking about how long are you going to be searching for participants for the study?
Thanks, Mary, for the question. If you're interested in doing the study that I posted around Dr. Rose's work, that's more immediate. So if you're interested in that, she would like to work with you immediately. But there will be other studies that we'll be doing of employers and education partners and students that will be coming down the road. But the one I posted is more time sensitive. Yeah.
Yeah, I'm trying to copy all the links into the chat so people can click on them that were on that last slide. So they're getting in there slowly. So if you were looking for one of those links, I'm doing that in the backside here.
And Teresa has an interesting comment just about community colleges. What I will say is I've been really impressed, Teresa, with the effort of the community colleges around the Bachelor of Applied Science and Behavioral Healthcare. They're really coordinated. So all the courses have the same title and the same name. And that's through all the community colleges. And what I will say to you is I already know that many community colleges will be emerging with these programs in the next few years. So it's just going to take some of them a little longer, but you're going to see more of them emerging, preparing the BHSS.
Yeah, and I think one of the other questions was around people who already have a 4-year degree. I think at least one of the programs, Bill, is offering basically like a post-bac kind of option, right? So I don't know if you want to say more about that.
Sure. I think it's it's the Department of Health has to have some way of putting guardrails around who's credentialed to provide this kind of care and treatment. And so while there probably are some folks with bachelor's degrees who might be really good, if they haven't participated in one of these programs, they're not going to be eligible. What they can do is contact, for example, Eastern Washington University or Spokane Falls Community College or like Washington Tech. And they can say, I already have a bachelor's degree, but I want to be credentialed as a BHSS. Can you help me with that? And they will. They'll look at that. There is a minimum number of hours that that student needs to take. And I believe if they've already have a bachelor's degree, it's a minimum of 30 quarter hours that they would have to complete along with their practicum. So, but the colleges have the discretion about making all those decisions about how to matriculate people through. EWU is probably best prepared right now with their certificate program to manage the people with a bachelor's degree. I think one of the thoughts I have about that, though, is it's probably more advantageous for a student to connect with a college close to them because of the practicum. So it's hard for a college on the east side to run practicums on the west side and vice versa. So so it'd probably be better right now to connect with one of our colleges on the west side, like Evergreen or like Washington Tech, or on the east side, EWU. Central Washington University will be starting their program next year in Ellensburg. So, a lot of these programs are just coming online and they'll probably have the option of doing post-baccalaureate training once they get up and running.
So do students have to identify their own practicum or internship programs, or are those kind of prearranged through the program?
It's a great question. It depends on the program. Some programs have a long history of already developing relationships and supporting their students with practicums and internships. So I think for any program where this is sort of brand new to them, it may be that they're also asking the student to help them with that. Mm-hmm. We're doing some training with our ed partners around the importance of supporting that and the level of involvement that they need to have. Again, it's familiar to graduate programs, a little more unfamiliar to undergraduate programs. But I would say most of our partners do a really good job of already having established relationships to help their students. It becomes a problem if it's a student who lives far away from the institution. Then it's harder for them, and they'll need the students' help with that.
Okay, great. We had one more question come in here, so I'm going to read this one before we have to wrap up. This question is, are there considerations for how BHSS training may go towards higher accreditation in social work clinical psychology?
I mean, I'll start with that answer. I mean, I think this is something we've thought about a lot. Is this part of a career pathway to those higher degrees, which would be independent practitioners not needing that ongoing supervision? And I think the nice thing about this is it gives you flexibility because you will have a bachelor's degree that automatically allows you to be positioned to be able to apply for some of those other programs. Whereas if this was more of an independent certification that wasn't associated with that actual academic credential, I think that would be harder then to go on in that career pathway. I think the question of whether or not any of the work you do as a BHSS out in practice, I think that there are some programs that explore apprenticeship, but as far as I know right now, there's no like shortcuts, into some of those higher degrees through the BHSS. I don't know, Bill, if you want to say anything else around that.
I was just asked that question this morning. I think there's opportunities for colleges and universities to work on those kinds of incentives. So within a university, they could create an incentive for their bachelor students to apply to one of their master's programs by giving some credit for that work. And I think that that's going to need to start within the institutions that offer graduate degrees first, and then potentially expand to collaborations with geographic partners around that. So I definitely see possibility in that, but it's going to be decisions that are made by the universities themselves. Yeah. And I think, as Anna mentioned, though, one of the advantages, this is not guild specific. So usually in other states, the bachelor level provider is a social worker. And this is someone who can go into any particular direction. They can go to social work, psychology, counseling, marriage and family therapy, medicine, and whatnot.
Great. Well, thank you both for being here today. That brings us to 1 o'clock, so I think we'll wrap it up. But that was really interesting, and I noticed we have a pretty big crowd here today. So I think there will be some interest in hearing an update once we have some people in the workforce. So we should definitely plan on doing that. So yeah, thanks again for being here, folks online. Thanks for joining us. I hope you'll join us again next Friday at the same time. And until then, let's all have a good weekend. All right. Bye.